Baik, Bapak Ibu sekalian, dalam sesi pleno yang akan kita mulai pada sesi 1 kali ini, diskusi kali ini, kita akan menggunakan bahasa Inggris. Jika Bapak Ibu ingin menggunakan dan mendengarkan dalam bahasa Indonesia, Bapak Ibu bisa menggunakan fitur yang ada di interpreter yang ada di dalam Zoom Bapak Ibu sekalian. Jadi kita akan ada 2 sesi, yaitu dalam bahasa Inggris dan dalam bahasa Indonesia. Assalamualaikum warahmatullahi wabarakatuh. Selamat siang, salam sejahtera untuk kita semua. Salam Om Swastiastu, Namo Buddhaya, salam kebajikan. Puji dan syukur kita haturkan kepada Tuhan Yang Maha Esa, karena hanya atas perkenannya kita diberikan untuk hadir dalam acara Pertemuan Jejaring Promosi Kesehatan Rumah Sakit yang diselenggarakan pada hari Rabu sampai dengan Jumat, tanggal 11 sampai 13 Desember 2024 di Hotel Grand Savero Bogor, Jawa Barat. Kami ucapkan selamat datang juga kepada seluruh peserta serta tamu undangan semua yang telah hadir baik secara luring dan secara daring. Perkenalkan, saya Iren yang akan memandu jalannya acara pada hari ini. Sebelum acara dimulai, marilah Bapak Ibu hadirin sekalian, kita menyanyikan lagu Indonesia Raya. Untuk para hadirin, dipersilahkan untuk berdiri. Pada hadirin kali ini boleh dipersilakan duduk kembali. Baiklah Bapak dan Ibu hadirin sekalian, sebelum kita melangkah ke acara selanjutnya, agar kiranya acara ini dapat berjalan dengan lancar, marilah terlebih dahulu kita memohon perlindungan kepada Tuhan Yang Maha Kuasa dengan memanjatkan doa yang akan dipandu oleh Bapak Sakri Sahabat Maja. Untuk waktu dan tempat dipersilahkan.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Bapak Ibu yang berbahagia yang saya hormati, marilah kita sejenak menundukkan kepala, bermunajat kepada Allah. Semoga kita diberikan kelancaran kemudahan dalam pertemuan jejaring promosi kesehatan rumah sakit dalam mendukung transformasi kesehatan. Mohon izin doa saya pimpin dan Bapak Ibu yang lain menyesuaikan sesuai dengan keyakinan masing-masing. Berdoa mulai. Bismillahirrahmanirrahim. Astaghfirullahaladzim. 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 Hamdan syakirin. Hamdan na'imin. Hamdan yuafi ni'amahu wa yukafi majidah. Ya Rabbana lakal hamdu kama yanbaghi li jalali wajhikal karim wa 'azimi sultanik. Segala puji bagimu ya Allah yang Maha Pengasih, Maha Penyayang. Segala keagungan hanya untuk-Mu ya Allah. Hanya kepadamu kami menyembah dan hanya kepadamu kami mohon pertolongan. Ya Allah, ya Rahman, ya Rahim. Kami bersujud di hadapan-Mu. Kami memanjatkan puji dan syukur kehadirat-Mu ya Allah. Perkenankanlah, limpahkan rahmat dan barokah kepada kami dan seluruh yang hadir dalam acara pertemuan jejaring promosi kesehatan rumah sakit dalam mendukung transformasi kesehatan di Indonesia. Ya Allah, kami berharap ridho-Mu. Semoga pertemuan jejaring promosi kesehatan rumah sakit ini yang akan kami laksanakan ini menjadi amal ibadah bagi kami, menjadi sebab dihapuskan dosa-dosa kami, serta sebagai pemicu semangat pengabdian kami, ya Allah. Ya Allah, ya Hadi, Engkau Zat yang Maha memberikan petunjuk. Tunjukkanlah kepada kami yang benar itu benar, ya Rabb, dan berilah kami kemampuan untuk mengikutinya. Serta tunjukkanlah kepada kami yang salah, nyatakan salah ya Allah, berilah kami kekuatan untuk menjauhinya. Ya Allah, ya Muqtadir, kami tidak berdaya dan upaya di hadapan kekuasaan dan keagungan-Mu ya Rabb. Tugas dan tanggung jawab promosi kesehatan di rumah sakit adalah amanah bagi kami semua. Berilah kami ini kekuatan dan kesehatan, tingkatkan kecerdasan dan kemampuan kami, prakarsa dan kreativitas kami ya Rabb, agar dapat terus berjuang meningkatkan pelayanan promosi kesehatan di rumah sakit demi terciptanya bangsa yang mandiri dalam kesehatannya. Rabbi adkhilni mudkhala sidqi wa ahridni mukhraja sidqi waj'alni min ladunka sultanan nasyira. Ya Allah, masukkanlah kami ke dalam golongan-golongan yang baik dengan cara yang baik ya Rabb. Berilah kami rahmat pada sisi-Mu ya Allah, kasih sayang dari sisi-Mu ya Allah, agar membawa manfaat dunia dan akhirat ya Allah. Ya Allah, ya Rabbi, perkenankanlah doa kami. Rabbana atina fid dunya hasanah wa fil akhirati hasanah wa qina adzabannar. Wa sallallahu ala sayyidina Muhammadin nabiyil ummi wa ala alihi washabbihi wa barik wasallim. Subhanaka rabbika rabbil izzati ma yasifun wa salamun alal mursalin alhamdulillahi rabbil alamin. Wassalamualaikum warahmatullahi wabarakatuh.
Baik, Bapak Sakri, terima kasih atas doanya untuk siang hari ini. Semoga kegiatan siang hari ini kita diberikan kelancaran. Amin. Berikutnya kita masuk ke dalam sesi Pleno 1. Baik Bapak Ibu hadirin, saat ini kita akan masuk ke dalam sesi Pleno 1 dan akan ada 2 narasumber yang saat ini memberikan materi dan informasi pada siang hari ini. Yaitu ada Bapak Arab Harlid selaku Chair International Network of Health Promoting Hospital and Health Service HPH Net dengan materi yang berjudul Recommendation from 30 International Conference on Health Promoting Hospital and Health Service. Selanjutnya ada Ibu Profesor Suti Chiao, MD, PhD, MSc selaku Task Health Promoting Hospital dengan materi yang berjudul Fostering Equity and Well-being Through Health Promoting Hospital. Dan selaku moderator pada sesi Pleno 1, yaitu ada Bapak Dr. Suherman dari IHPH Net. Kepada Bapak Dr. Suherman, waktu dan tempat kami persilahkan.
Terima kasih. Assalamualaikum warahmatullahi wabarakatuh. Bisa didengar? Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh, Bapak.
Alhamdulillahirabbil alamin, rabbi shrah li sadri wa yassir li amri wahlul 'uqdatam min lisani yafqahu qawli. Amma ba'du. In this moment, I would like to thanks for the two resource person from abroad. Come from Sweden, Mr. Ralph Haptich, and also the second one is come from Taiwan, Professor Suchi Cho. It is very involving in our activities. We would like to introduce one by one, and when we one by one we will present all of the material, and after that we would like to directly for discussion because time is very constricted to us. Now, I would like to introduce the first speaker, Mr. Raf Hafid, is distinguished healthcare leader with extensive clinical experience in anesthesia and intensive care. He has served in various high-profile roles, including the healthcare and services director in the region of the Pasta Götaland, Sweden. He is also currently as a chair of the International Network of Health Promoting Hospital and Health Services and National Coordinator for the Swedish HPH network. His strategic leadership in the health promoting healthcare is the chairman of the Swedish branch of the International HPH network highlight his commitment to health system improvement. As an accomplished with lecturer and author, it also contributes significantly to medical education and practice, notably in infectious anesthesia. He holds a PhD from the Gothenburg University and Medical School and the MD with the specialization of anesthesia and intensive care. May I, Raf, would like to introduce myself, maybe as the moderator. My name is Suherman, the former Indonesian National Health Promoting Hospital Coordinator since 2012. The time is yours. Maybe you can also directly manage your presentation directly from your, because you have to become a choose as a host. Please, it's time for you.
Well, thank you very much, Dr. Surman, for this kind introduction, and I'm so honored to be invited to your meeting. I see there's quite a few delegates here throughout the country of Indonesia. I will try to share this. Let's see now if this works. So do you see my slide in full view?
Yes, of course, you are right. Okay, please go ahead.
Okay, so thank you again, and ladies and gentlemen and distinguished colleagues. It's a privilege to be here today. And as I said, I'm honored to be invited as part of this discussion on optimizing the implementation of health promotion in order to support a transformation of primary healthcare services, especially as I understand in Indonesia. You already introduced me, Dr. Surman, as the chair of the International Network of Health Promoting Hospitals and Health Services. And I'm inspired by the commitment shown by your network as we met in Hiroshima a few weeks back. You work very hard on health equity, patient safety, and community health resilience. So for today's topic, I will address some different parts of health promotion in order to discuss health and health promotion. We need to address the determinants of health, and I will start with that, an overview. I have also been asked to give some feedback from the 30th International Conference in Hiroshima, and I will do that. And I will address the role of health promoting hospitals and healthcare services in strengthening the implementation of primary care. And I will conclude with some challenges and opportunities. I hope this will be manageable within 30 minutes. So let's get started then. Before I go into depth in these matters, I always show this picture because sometimes we tend to be confused in what is preventive healthcare and what is health promotion. And I will come back to this picture, but I will stress the point that prevention focus on disease and preventing disease, which is extremely important. And health promotion focuses on health and well-being, and actually is the WH definition is to strengthen people's ability to take care of their own health and to create an environment that promotes health. So this we need to keep in mind, the differences between preventive health care and health promotion. So let's start with the determinants of health. What actually are the cornerstones of our health? And as you all are familiar with, I'm sure most of you have seen this picture or similar pictures. There are a large impact on our age, sex, our physiology, our constitutional factors, heritage, etc. And that's, of course, a very vital part of our health. And then above that, we have the individual lifestyle factors, such as smoking, eating habits, moving, alcohol, etc. And around that, we have the social and community networks, which are constituted from a large part of very many different things, like education, work, living conditions, etc. And then as a frame outside of this, we have the general socioeconomics of a country or of a community, cultural and environmental conditions. So if we look closer on the sorry, I'll switch this. On the social determinants of health, we learn from Sir Michael Marmot, who in 2008 wrote the report Closing the Gap, that the educational level is very closely connected to our health. And how is that? Now, education is related to the chances of getting a job. If you have a job, you have the chance of getting a decent income, which in turn affects your living conditions, your lifestyle habits, your eating habits, etc. And together, these social determinants of health are the source of what we call the social gradient. Now, another way of visualizing or illustrating the social gradient of health is this picture, which you may be familiar with as well. And it points out that we have an individual responsibility for our health, but the health hazards, the burden of health that we are carrying is not equally distributed within the populations, as you're well aware of. But some people are born with different handicaps or different diseases that makes it difficult to achieve a good health. But we also have the social determinants of health that are in the that are shown here: education, environment, food, unemployment, etc., etc. So this builds up the social gradient, which is illustrated in this picture, which shows us the life expectancy. And here I have made the assumption that it's better health to be alive than to be dead. So life expectancy is quite a good factor to measure. And it shows us the life expectancy in comparison to the neighborhood in which you live and the neighborhood income deprivation. And now this are figures or data from England, from the United Kingdom, but this is the same throughout the world. It doesn't differ in any countries. And as you can see here we have the least deprived and we have the most deprived. And you can see that the most deprived live shorter, they have a shorter life expectancy than the ones in the middle. But that's not the full problem. The problem is that it's a gradient. So the people near the top have longer life expectancy than the people in the middle. And the people at the very top have longer life expectancy than the people close to the top. So it's a gradient. And I will show you this slide with pictures from Sweden, where we have looked at, this is remaining life expectancy once you have reached the age of 30, but it more or less shows the same. And here we have people with basic educational level. Here we have a upper secondary education level, and here we have a higher educational level. As you can see, the people with high education live longer than the people with low education. And what we can see here, at least in Sweden and in many countries, is that the gradient, the difference between the high educated and the low educated is actually growing from the early 80s to and if we prolong this, we can see it's still growing in the 2020s. So this, of course, is something that we need to address if we are talking equity in health, and I will come back to that. These are the books that Michael Marmot have released. He's written more than that, but one quote that I want to share with you is, and I've actually talked to him, and he says, "What good does it do to treat people and send them back to the conditions that made them sick?" Now, this is something we really need to consider. And this topic was actually the theme of the 30th International HPH conference in Hiroshima. The contribution of health-promoting hospitals and health services to health equity. Now we're talking health equity. And the major topics that I would like to share with you, insights from the Hiroshima conference, is how we address the social determinants of health in order to reduce disparities in access to health care and outcomes. So health equity was a very important part of the conference. We also listened to how we can use digital innovations using technology to enhance patient engagement and deliver accessible care. And in that sense, we also need to address the topic of digital health literacy. I will come back to that. And finally, we discussed sustainability, aligning healthcare delivery with environmentally responsible practices to support planetary health. If we start with the matter of health equity, this is a picture that you may have been encountering, but it shows very clearly the difference between equal care and equity in care. Now, equal or equality means we treat everyone in the same way. But not everyone has the same preconditions. Not everyone has the same vulnerability. So we need to address the people we meet in different ways, depending on what their special needs are. And in order to do that, we need to address the social gradient again, and we need to identify the vulnerable populations and what their specific needs are. I'm not so familiar with the Indonesian healthcare system, but in Sweden, anyway, we have a tendency to treat everyone more or less the same with standardized treatment procedures. And that will not create an equitable healthcare. And we also need to develop targeted health promotion and prevention programs for these vulnerable populations. And very important is to train our healthcare professionals, especially the medical healthcare professionals, the doctors, to recognize and address social determinants of health and understand the impact of them. And finally, to address the social gradient, we also need to create partnerships with community organizations in order to support social needs, not only medical needs. So again, this picture that I started with, we need to distinguish the matter of prevention versus health promotion, but examples of preventive measures are vaccinations, regular health checks, screening tests, and advice on healthy lifestyle habits. And if we look on examples of health promotion measures, it's including educating the population about healthy lifestyle, not only giving advice, but educating the population. Promoting physical activity, psychological well-being, and social support. And I think these matters are very good examples of where the primary care has a very important part. If we move on to addressing the way we address medical issues, I think that we are trained very well, especially as doctors, in a disease-oriented approach, which means that we start by looking at the disease, what is wrong, we assess, we treat, we prescribe. And that's, of course, important. That's what the patient are expecting. But at the side, we have some kind of understanding for who is in front of us, what is this person, how is the educational level, do we have a dialogue, can we support and motivate? And this needs to be, I think, balanced by a health promoting approach, where we start by looking at the person, understanding the conditions from where he comes or she comes, understanding what are the needs of this person and try to support and motivate it for a change in life. And at the same time, of course, we assess, treat, and prescribe. Now, this balancing is difficult, but that I think is a vital part of changing our healthcare system into more health promotion. So let us look at the digital innovations and the opportunities we have there. Of course, we are living in a world where yesterday we had the Nobel Prize winner here in Sweden. I don't know if you followed it, but I did. The Nobel Prize winners were actually the winners due to their research on artificial intelligence. Now, can we use this in health promotion? Yes, we can. We can use it particularly in predictive analytics and, of course, in patient monitoring, which are essential for a sustainable care and in order to optimize outcomes. We can use telemedicine and digital health. This is a revolution, and it reduces the need for travel and physical hospital visits. We can reach people that we could not reach before, and we can lower carbon emissions by we don't need to travel as much. And you in Indonesia, I think you are consisted of, what is it, 20,000 or more islands? Of course, using telemedicine, I'm sure you already do that quite a lot, but that's, of course, of vital importance. I will skip the robotics in minimal invasive surgery because it's not so applicable in general practice, but we can see that we have future innovations in health promotion, where we can have clothes that will monitor our heart, etc. We can monitor and support preventive care, reduce emergency visits, etc. So using digital innovation is of great importance, but at the same time, we have to be aware of what we call digital health literacy. Not everyone has a good health literacy when it comes to digital, and not everyone has the possibility to use these tools. So that we have to address as well. I will conclude, go further. Well, I will conclude with some slides on the climate and healthcare. It's a paradox actually, because the healthcare system is both a responder and a contributor to climate change. We need to take care of the consequences of our climate. Of the climate change, such as, I will come back to the different aspects of that, but we need to take care of more and more people that are being sick due to climate change. At the same time, we, as a healthcare provider, we are very energy intensive, so we contribute to global carbon emissions. We are the third largest contributor to global emissions. And this is a need for an integrated approach to sustainability. How can we reduce our carbon footprint? As I said, the climate change affects people's health by this year we have the warmest year ever that has been measured, and I think this is what's happening every year. We have the warmest weather. We have more and more extreme weather events. We have a rise in infectious diseases, especially in Europe, we can see that. And of course, we have an increased respiratory diseases. There are parts of the world where children are not allowed to go outside due to the poor air quality. And we can see here that we actually account for quite a lot of carbon emissions due to energy consumption, transportations, supply chain, medical devices that we need, waste generation. I'm an anesthesiologist, so I know that our gases are really bad for the climate. So I would like to see the health promoting hospitals as climate leaders. If we are actually talking health promotion, we need to promote sustainable patient care. We need to engage our staff in eco-friendly practices. And I would say that the health promoting, the HPH principles align very well with sustainability, because they emphasize preventive care, community engagement, and reducing the environmental impact on healthcare services. So health promoting hospitals should serve as models for integrating sustainability into every aspect of care, such as building design, medical and nursing practices, patient education. We can see that there is a huge importance of the built environment for health promotion, because well-designed healthcare facilities support patient recovery and well-being, but they also save energy. So this is a topic we need to discuss more. Well, finally, we come to the role of HPH in strengthening primary care. And I think that, as I've said a couple of times, we need to integrate with the community service. We need to establish partnerships with local health providers to ensure seamless care transitions and comprehensive service delivery. We also need to work on the health literacy, supporting individuals and communities to make informed health decisions and adopt preventive behaviors. We also need to transform our organizations to become more health literate in order to meet different needs. And we need to train healthcare professionals in health promoting principles to enhance quality of care across all levels of service deliveries. By aligning with these goals of primary care, I think that health promoting hospitals and healthcare services can improve access, equity, and outcomes. There are, of course, even though there is a great potential for health promoting hospitals and health services to transform primary care, there are some challenges, such as infrastructure and resources. We need to address gaps in facilities, technology, and workforce capacity. And we need to advocate for policies and investments that prioritize health promotion as well as prevention. And we need to build partnerships, as I've said a few times, beyond healthcare to address the broader determinants of health that I started this discussion. But at the same time, I think that we have the opportunities to include digital tools, community assets, global networks, etc. So to conclude, I want to say that looking at the future of healthcare, health promoting hospitals represent a beacon of innovation and equity. And I believe that everyone in the healthcare sector has a role to play in promoting sustainability and reduce climate change. And therefore we must continue this vital work together, inspired by the shared vision of an equitable health for all. And thank you very much for your attention.
Thank you so much, Ralph, for the nice presentation, and not very broad, but it is very deep from our situation in Indonesia. Maybe I would like to give maybe one or two presenter to become a question on your presentation. Could you please? Because I would like to separate between you and also Mr. Cho, because about the time, maybe constraint of time. Excuse me, Mr. Cho. Yeah, okay. Is there any question from participant online or maybe in the house in Bogor? And you could also ask in Indonesia language, or maybe I would like to translate it, or maybe you can directly ask in English. Please come to the forum. Is there any? The participants across of Indonesia, above than 1,000 hospital belong to the vertical hospital, belong to the Ministry of Health, maybe the private hospital, and also come from the district, municipality, on provincial hospital. I would like very happy because it is the big meeting, and across of archipelago joining with our meeting today. Hopefully one of them would like to ask, because it is very broad situation and quite deeper without what we have already doing in Indonesia. Maybe any one of you would like to ask indirectly or in Bahasa. Before we started, I would like to share about some information about Indonesia implementing of the HPH and also the Green Hospital, including implementation of top 10 agenda of WHO. It is very concerned that Indonesia Minister of Health was already giving some award to the hospital who is already implementing agenda on the standard of the WHO working group on the HPH, PPH standard, alpha and beta standard, and also we also implementing some of the hospital into the 10 agenda of WHO. What do you think about the issue of the green and the healthy workplace in Indonesia to compare with the issue on the climate impact, what you have already suffered in Europe, maybe in other countries around the globe? Could you ask Ralph, please listen while we are waiting for the question from participant?
Once again, Dr. Surman, you want me to elaborate on?
Yeah, Yeah, we would like to elaborate because before this, we have already implementing issue on the green hospital based on the 10 agenda of the WHO, and
I understand.
also the composer about the issue on the climate impact. What do you think about this situation? Is this stuff affordable, or maybe it need for the renewable about the standard and also about the activity? Please.
Well, I think that it's great to hear that you have already implemented this issue. I think this is something that is very different in different parts of the world. Some of the parts are very concerned about the climate. I think that Asia is very climate concerned. In Europe, it's not at all as big a thing. We in Sweden, we do not actually yet, we have not yet started this journey on adopting the green hospitals and the impact of the climate change. Maybe because we have not been so badly affected by the climate change yet, but I'm sure that we will recognize this. So you have my greatest support in working with this, and I think it needs to be even broader and deeper, this work. We need to
Thank you so
immediately address the issue. That's my thought.
Is there any question or maybe suggestion from our participants online or the offline? Is there any? Please come to the forum. The second question maybe I would like to share with you to Mr. Lab. In our country, nowadays, the Minister of Health was already introducing the 6th agenda of the transformation, how the health system in Indonesia should be adopted in the new situation of the surrounding, and also transforming about about the budgeting for the health, how the transporting for the primary health care, secondary health care, and also from the human resource and the concept of that. And also adopting the new technology. Based on your presentation about the personalized medicine and also using the genomic for the new era from the next agenda, would you think this need for the transformation should be sustainable also, or maybe other?
Definitely. I think that we have a huge opportunity here in addressing a personalized medicine. And as I pointed out, since we are so different, we have such different needs, we need to be better in identifying the vulnerable populations and addressing them in a different way. And I think that genomics is one part of it, of course, but also the level of education, that will always be a factor. Even though we have genomics, there are other factors, social gradients, as I said, social determinants of health that we need to address. And I also think that the transformation from focusing on hospitals to focusing on primary care is very important, because the primary care has a better possibility to address the population before they become patients. And that's what we need to do. We need to prevent the disease to occur. And I think that the hospitals are more built to take care of the people that needs treatment, but the primary care needs to align with the community and work with persons that are not yet patients, if you understand the difference here.
There is two questions from the audience, Prof. The first audience come from Hermini. Hello, sir. I'm Rini. I would like to ask to Mr. Lab. My question is, what ethical consideration should be need in the hospital, especially for hospital that are just building health promotion in our hospital? Please, Ralph.
Very good question. I think that when it comes to ethics, we need to start by considering that every person is worth just as much as any other person. I don't know what the English word, the human rights. That's right. The human rights. That is the base to stand on, because to be honest, we do not treat all patients the same, even though we are not always aware that we treat them differently. But so I would say human rights, when building health promotion, start with human rights.
The question,
yes?
the question is very specific, how to implementing artificial intelligence technology in health promotion.
I'm not the expert on AI, but I use it quite a lot. And I think that this will provide each person, each patient with a tool before, to understand their own disease, their own situation. So they can start with using an AI tool to get advice on how to, on living conditions, living habits, etc. So I think that it will move some of the focus from the hospitals to the individuals. We can, as I said, health promotion is about strengthening people's ability to take care of their own health and to create an environment that promotes health. So AI can support that very much, I would say. But at the same time, of course, we need to be cautious on the...
Health promotion objectives.
Well, when it comes to sustainability, we have two issues. We have social sustainability and we have the climate sustainability. And if I start by the climate sustainability, each hospital or each healthcare system should look at their own procedures. How much disposables are we using? How are they using what kind of drugs are we using? What kind of food are we delivering? Do we buy food from one place and transport it do we have long transportations, etc.? So you can look at your own procedure in each hospital. And that's for the climate sustainability. I just listened to Australia, where they do not use almost any disposables. Instead, they use reusable. So that's one thing. When it comes to social sustainability, it's about creating an equal society. So equity in the society is the base of social sustainability. Unequal societies do not sustain.
Okay, the last question from group is about how to support health-seeking behavior. What aspect of the health promotion must be improved in the hospital? Thank you.
Once again, I didn't hear you quite. How to?
To support health-seeking behavior. Health-seeking behavior. What aspect of the health promotion must be improved in the hospital?
I'm not quite sure I understand. How to address, the health...
Support health-seeking behavior.
Health-seeking, healthier behavior. Sorry. Yes, how to... Now, this is very, very good question. This is one of the most difficult things that we do have. Because changing, we can go to ourselves. If I want to change my own habits, it's not that easy. But there are issues. I would say that motivating interviews, which is one very interesting tool, MI, I would look into that. That's a way of addressing people and motivating them to change life habits. You can look closer into that. Just Google on MI, so you can see that.
Okay, the last question is about From Wahyu, from our hospital has performed total knee replacement surgery using robotic technique. Recently, you just mentioned a robotic minimally invasive procedure. Is there any truly possible? Could you explain how the procedure works?
Well, I mean, we use robotic minimal invasive procedures for many procedures. I think it's already a common procedure. I'm not quite sure what's. I say yes, it's truly possible. I wouldn't go into detail on how the procedure works, but in our settings, we have a surgeon that actually are using a robot, or that the robot performs the procedure, and it works perfectly. Prostate cancer, for example, is a perfect procedure for robotic, and I think it will grow.
Next question. Excuse me, sir. How do we have promote our health services so that the public doesn't get bored on getting message related to the health promotion continuously?
Good question. I can see you have the same problem in Indonesia as we do in Sweden, because it's very easy to come with fingers and say you should do this, you should do that, etc. But what I think is one way you could do it is to actually address certain age groups that are, if you meet with you could summon a group of people, let's say everyone that turns 60 this year, everyone in the age of 60 will get a note to come to the primary care to discuss their life habits. Not everyone will respond, but the ones that do come, you can have a discussion. So you do not go out widely to everyone, but you do target your measures towards a certain group. And that's a way of not boring or tiring the whole population by having big billboards. You shouldn't drink, you shouldn't smoke, etc. So I think that's a good way of
Thank you, Raf. I would like to close the time for you because we know that there's so many participants would like to know more about the HPH activity, mostly in the clinical health promotion in your country and abroad. But I think that kind of constraint is very limited. But I hope that maybe sometime maybe you can also come back to Indonesia and also suffering that the HPH meeting should be done in Indonesia. We are waiting for this good news about this session. Thank you so much for time of observation. Yeah.
Thank you for having me, and it was a pleasure. I will be glad to come back if possible. Yes.
Okay, thank you so much, and then thank you for your kind, and hopefully that you can also leave from the link. And I would like to continue with the Professor Suchi Cho from promotion. Before this, the Professor Suchi is also the DG from the Taiwan Ministry of Health, and hopefully, Professor Suchi would like to share about that issue. Please, the time is yours.
Thank you, Dr. Suleiman. It's so great to see you again. And also, I would like to thank the organizer, the Ministry of Health of Indonesia, for the invitation and for organizing this very wonderful event. And it is truly so great to see many of the Indonesian colleagues in Hiroshima and to see you again here virtually. So my topic today is fostering equity and well-being through health promoting hospital. And I will introduce global policy context for health equity and determinants of health. And then I will talk about what do we need to know about determinants of health. Although Rolf has mentioned many of these, but I think I will elaborate further. And then I will talk about what needs to be done. I will give some examples. And then the conclusion. So can you see the slide moving?
Yes, of course.
Okay, great. So first, the global policy context. As you have seen, and I'm sure you know that the WHO definition for health promotion is the process of enabling people to increase control over and to improve their health. Actually, there are a few keywords here. The green colored keyword is people. It's not only to help patients, and it's not only to help persons, it's to make everyone, all the people, to have better health. So it means to promote health for all. And the word enabling actually is different from the word empowering. Enabling means to make people be able to control their health. For example, to avoid consumption of trans fatty acid, for example, and to support them to do physical activity every day. But how do you do that? You ask similar questions. Actually, through health education, the effectiveness is limited. But if you have public transportation, well-developed system of public transportation, people take it for the everyday transportation, then they are able to do more physical activity. So enabling is the word to make healthy choices easier, okay? And WHO mentioned the determinants of health as the range of personal, social, economic, and environmental factors that determine the healthy life expectancy of individuals and populations. And so, as Dr. Suleiman mentioned, it's broad. Yes, the trend is to go into the wider perspective, which determines our health. It's the context where we live, which determine our health. So that means individuals for having poor health or merely asking our patients to change just by giving them information is not a good way to get everyone doing the healthy behavior. We need to look at the context, and we need to help change the context, not always directly from us, but we need to facilitate that. But how? I will tell you how. So, and then you see this graph showing the healthy cities and health promoting city initiatives. It's actually, we call it ecological approach to health promotion as compared to individual approach to health promotion. So in addition to help everyone to provide health education to our patients, we also need to look at the context where they live, they work, and where they move. And then this is the data from the USA, and the WHO has similar data, which showed that health behaviors accounted for 30% of people's health, and clinical care accounts for 20%. How about the other 50%? Actually, it's accounted by social and economic factors and physical environmental factors. So we call physical environmental factors as environmental determinants of health. And these social and economic determinants of health is very important. So all these are the determinants of health. And this is the new general program of work for WHO from 2025 to 2028. For health promotion, WHO listed two important things. The first is to respond to climate change, and the second is to address health determinants and the root causes of ill health. So this is at the center of the global health governance. Okay, so what do we need to know about how to tackle determinants of health? So here, WHO said, health promotion is fundamentally concerned with actions to address the full range of potentially modifiable determinants of health, not only those related to individuals, but also those that are largely outside of the control of individuals and groups, such as income and access to resources, education, employment, and working conditions. We call them social determinants of health. And also the access to appropriate health services and the environmental determinants of health, such as global warming, air pollution, and water supply, etc. And how do we address this broad range of determinants? We address through a combination of strategies, including the promotion of health in all policies and creation of supportive environments for health, and also by strengthening personal health literacy and skills for health. So this was listed in the WHO report to closing the gap in the generation. There are three overarching actions. First is to improve the context, the daily living conditions. And second is to tackle the context through distribution of power, money, and resources. And third is to measure and understand the problem and assess the impact of action, which means to do health impact assessment and health equity impact assessment on the interventions. And those interventions might be interventions in other sectors, such as what I mentioned, the public transportation system, the intervention on quality education for all, etc. And this picture was provided by the former director of US CDC, Tom Frieden. He talked about the health impact pyramid. He said that according to the unit impact, the impact per unit of input of interventions, you can see the impact from counseling and education is the smallest. So it's high labor, high individual efforts. It's very labor intensive. However, it achieves lowest health impact. And long-lasting protection interventions such as mass vaccination or to change the context to make individual health decisions, yes, to move vending machine from the primary school so that children will not be able to get junk drinks in the schools. These public health interventions achieve moderate impact. And then tackling health determinants at the upstream of all determinants of health, it will achieve highest population impact. So health education is important, but we should not only rely on it. In addition to doing health education, we also would like to link or advocate for the other interventions to the governments or to the communities so that we work together to shape healthier contact for our people. And this is a report published in Lancet this year. It's about a call for action to shift the orientation of tackling liver disease. So even for medical problem, let's see, how does it say? It says to call for action to shift the orientation. So this every area indicates the contribution to liver diseases. So you can see the biggest contribution comes from structural determinants of liver health, which means the determinants of health I mentioned. So the interventions will be economic and social stability, physical environments, population health literacy, food security, etc. And then following that, you can see alcohol and cardiometabolic risk factors and virus. And what should we do? They talk about public health interventions, population level policies, such as fiscal approach, for example, to increase taxation on alcohol and to restrict marketing of alcohol and to provide mass vaccination for example, hepatitis B virus and to treat hepatitis C infection, for example. So these are the second level intervention, which will achieve very high impact and then followed by the other things. For example, clinical health education, and for example, early diagnosis, and for example, primary care, multidisciplinary care, and then hospital treatment, etc. So even in clinical medicine, they also know that we need to tackle determinants of health from the upstream. And for what you are familiar with, for example, tobacco control, among these measures, such as MPOWER, the strongest effectiveness and most universal effectiveness comes from to raise taxes on tobacco. You see, you don't need to spend money to control tobacco hazard. You might even get extra revenue from tobacco control, which is to raise taxes on tobacco, and it achieves universal improvement. And then, actually, with this economic approach, you get revenue to support your clinical interventions. You ask about budget. If you don't have budget, how do you do better health promotion? How do you build IT? Here, you see, when you apply the correct approach, you get better outcome and you get revenue. And WHO and the OECD now is talking about well-being economy. This is part of the well-being economy, to make unhealthy things more expensive and to get the revenue to promote well-being and health promotion. And you see, according to Taiwan's data, when we raised tobacco tax in 2009, we saw a significant decline in adult smoking rate. And you see the strongest decline came from people with lowest education who have highest smoking rate. They have highest smoking rate. They were of the lowest socioeconomic status. And this economic intervention helped them most. They achieved 20% reduction in the smoking rate. So it helped. You can see it helped shorten the gap. The difference between the highest and the lowest, you see, it's now narrowing. So let me give you more examples. So how do we incorporate health equity into health promoting hospital works? First, we need to provide education and training, like what you are doing here, to make our health promotion professionals know that what's determinants of health and how would they help us. So when politicians ask you, you can deliver the right message. You won't say, oh, we just do health education and that will be the best. No. We say, we already are doing a lot. but the return is not as satisfactory. We would like you, for example, the government, the public health sector, or the prime minister, or the mayor, to do a few things to also support the people. So we need to train and educate health professionals. And second, we need to have evidence. We need to have data. For example, like what Prof showed you, in Taiwan, we also had this data. And for you, you can have the data not only in the national level or the county or the city level, but also in your setting. HPH is about the setting, the health promoting setting in the healthcare sector. So in your setting, you have your quality data, healthcare quality data, you have the smoking rate, etc. And you do analysis to see the gap between your patients of different socioeconomic status, between the quality of people with different educational level, for example. So we can also do the analysis within our setting. And then for the clinical care situation, we can do social needs assessment and social prescribing. So we do not only assess risk factors, we also assess social needs. And then we need to have a list of resources in the communities. And then we can do social prescribing. And we can also develop community networks to support our patients. And fourth, about at the organizational level, they can look at how to support our employees, such as the HPH is an employer, and they are managers, and they are commissioners, they purchased. So when you do green hospital, you have green purchasing, right? You have green management regarding your energy, etc. So at the healthcare organization level, we can do these things. And at the community level, we work with community partners. And when we work with community partners, we serve as advocators. We advocate among healthcare societies, but we also advocate in the community and in the city and in the country. Okay, so this is the Lancet Commission on Education of Health Professionals. In 2010, they already said that we were not educated about health determinants. So we need to transform our learning to produce change agents like you and to create leaders. We need to know about determinants of health, and we can advocate for the broader context, the society and the city and the communities to change the environmental context, the social context, etc., to help our people. And you can see different health professional associations have endorsed such approach, and they want to do something about it. And about the monitoring, you can see this is WHO European region. They monitor not only the differences in health status, they also want to monitor the progress on policies to improve health equity. So they monitor not only health services policies, but also income security and social protection policies, living condition policies such as housing, and social and human capital and employment and working condition policies. It's WHO Europe to do the monitoring on the other sectors. And in the US, you see, for healthy people, 2030 of the US, they say social determinants of health have a major impact. So they are a key focus of healthy people, 2030. So they listed these: education, access, and quality, household economic stability, social and community context, neighborhood and built environment, and healthcare accessibility and quality. These things as the key determinants, and they do monitoring. They have indicators for each one, and they do monitoring on the progresses. That's what the WHO Europe is doing. So we can leverage the power of data to work with other sectors and to advocate for improvements. And then at the organization level, you can see US is an example of top-down approach. So with the national priority, you see this is the American Hospital Association. They have this health equity roadmap for their members. They have this assessment tool for health equity transformation for American hospitals. And they listed 6 domains for transformation, including culturally appropriate patient care, equitable and inclusive organizational policies, and collection of and use of data, and then the diverse representation in leadership and governance, and community collaboration, and systematic and shared accountability. You can see they listed those things I mentioned and then within each with each domain they have indicators, and then the American hospitals, they can do the self-assessment to transform the hospital, the organization, the management towards a more equitable organization. Okay, and then at the clinical level, you can see American
5 minutes
Academy.
more.
Yeah, it's almost the end. American Academy of Family Physician, they have this Everyone project to support family physician, the primary care providers for social prescribing. Okay, so they listed I will show you this, the next slide. They have this social needs screening, and then they have this neighborhood navigator. It's web-based navigator, technology to support your efforts to improve equity. So after doing the social needs screening, they have this neighborhood navigator. So the clinical care providers, clinicians, or some link person can help link the patients to the resources for food, housing, transportation, or employment aid, or legal aid, or financial aid. Okay. And then another example is the bottom-up approach. For example, healthy aging for all. WHO listed the determinants of healthy aging for all, including economic determinants, etc. Likewise. And then there are domains of actions to support healthy aging for all. You can see they are the environments. But they also include clinical services, but they also include environments. And the UN decade emphasized healthy aging for all, which means equitable healthy aging. And then it includes healthcare and long-term care, but also the enabling community environments. Okay, and it's like what I showed you. And then at the clinical setting, for example, in Taiwan, we have this age-friendly healthcare framework. Within our setting, we also emphasize the management policy, we emphasize the communication and services, which is the social environment. And then the physical environment, about physical determinants of health. So to make our healthcare more barrier-free, more friendly to older persons. And then in the care process, in patient assessment, we include a social needs assessment, okay? And also we include working with the community to improve continuity in the community. And this is the WHO social prescribing figure showing you that you can have a linked person. He or she doesn't have to be a healthcare professional. He or she just needs some training to support the clinicians. And then we can do, she can help link to financial support, housing support, etc. Like what I've mentioned in the USA, but also for healthy aging, they also link to lifelong learning resources, to social at the national, likewise. At the national level, I supported our parliament to have strong generation policies and economic development policies. Currently, we are doing a legislation to ensure active aging for all. And then for breastfeeding, for example, likewise, I'm only to once again to show you that we can work at the micro level, education and counseling for breastfeeding. But then we also need to improve the meso environment, which is the setting. So we do baby-friendly hospital or health services accreditation. And then at the macro environment, we need to advocate for a ban of marketing of breast milk substitutes, for family-friendly policies, etc. And type of data showed they are all important. So in conclusion, for HPH initiative, we have the correct target population. We are system-oriented. They are all correct. The only thing we need to do is to expand our focus to be more system-oriented and to include social needs into our patient intervention and also to work with the community. So that's the all of my presentation. Thank you for your attention.
Thank you so much, Professor Chichu. I think it is a very detailed information about what you have already done in our country and implementing from the WHO standard around the globe. Thank you so much. But one question from you for you to respond for your presentation come from Wahyu. Rising tobacco taxes seems challenging since tobacco is one of the country's largest revenue sources. In increasing tobacco taxes, the only way to reduce smoking-related diseases, do you have any tips or strategies to encourage the government to address this issue? Maybe it's clear, Professor Chi?
Yes, it's very challenging, I can guarantee, because I personally went through that. It's difficult. But you see, that's where we leverage our influence. You are the experts, and you provide the smoking cessation education every day. And you found it very difficult. And you learned that MPOWER. So in addition to clinical cessation services, ban of smoking in public places, and to raise the taxes. Those two are also very important. So whenever you have the opportunity, you speak to the decision makers. And we need data to support us. For example, actually we showed the social return of the tax rates. We have the price elasticity. So we have the data. You can have the data from WHO, or your government can do your own simulation data. We ask people, if the price was raised to this amount, would you start smoking, etc. Then you can have your data regarding how much would be reduced for each, for example, $10 of raise of the tax. So you have the data. So you can show the government that this will improve the productivity. And you need timing to do that. For example, when the government is facing the difficulty of budget for health care or for long-term care, the government needs budget. If they raise tax for everyone, if they raise the general tax, there will be a lot of people who are unhappy. But if they raise the tobacco tax, it's only the 20% or 15% of people who smoke might be unhappy. And according to our data, only 40% of smokers would be unhappy. The other 60% said, okay, raise it, then I will just stop smoking. Okay, so when the time is right and you provide the correct information, you tell the politician, here is the way you get the money, and you upset fewer people than raising the tax for everyone, for young people. No, this is only those who smoke might be unhappy. Okay, so you can have those arguments. But first of all, we need to be prepared. So when that time comes, or when politicians ask you, you can propose the correct and the the amazing solution to them. And they might think about it. And they might decide, okay, if I had to upset my people, do I upset a lot of them or just a few of them?
Thank you, Prof. Suci. The second question is come from Kisiana from RSCA Graha Bunda. Dear Professor Suci, thank you for your insightful presentation. What are some applicable non-monetary incentives we can use to foster cross-sectional partnership? Is clear, Prof?
Non-monetary, okay. I think it's very important to show co-benefits. For example, for universal health coverage, actually when people are healthier, they have higher productivity. And this will support your GDP growth, okay? And with GDP growth, your government will have higher income and they can invest in education. But in another way, you say, for Ministry of Education, you say, oh, it's important. Education is helping our people to be healthier. Whenever the minister would like to say something to get more budget, you help him or her. You say, oh, that's so important according to our data. It will be beneficial to the whole society. Okay, so if you are supporting the other ministry, they thank you. And next time, when you want to do health promoting school initiative, they are happy to work with you. So you can use different ways to help one another. Sometimes you tell people they help us, you thank them, but sometimes you tell them that you help them, and so that they might be willing to support us. Yeah, so it's a mutual way. We call it synergies or co-benefits or the virtuous cycle, the good cycle for doing this kind of sustainable development, or we call it well-being governance. When we focus on well-being, starting from any point, can generate this positive cycle for each other.
Thank you, Prof. Suci. The last question is come from RSUD Samarinda, Radiana. Dear Professor Suci, I come from province of the country. The majority of people have low education and low middle class economy. We also have minimal resources in public. Do you have any method to educate people and action that our hospital can do reach equity and well-being of people, especially in my region? Thank you, Prof. Clear, Prof?
Thank you. Thank you. As I mentioned, there are different levels of interventions, right? From the national level, from the city or community level, and from the organization or the hospital or clinic level, and then from the clinical service level. So let me start from clinical service level. For example, in your province, so you know there will be a lot of patients with poor income. And with the poor income, they might not be able to come for the service regularly. So according to your computer data, you know who were missing. So you reach out, or you have the outreach services, the home services. But at the same time, I want to say that, so if your social services department can provide you with a list of social support or financial support, then when you have such kind of patients who need financial support, you can serve as the link person to connect your patient to the social welfare resources. In this way, they get the money and they can have better nutrition. And at the same time, you might also link with the employment support sector. And when the patient gets the job, he or she has better income and they are more capable to control their eating and their physical activity. So you can link them with those resources to help them. So this is at the clinical level we can do. But you need to build up the list of resources So you ask about how technology might help. So look at the example I show you from AAFP. They have this web-based resource list. So with different categories, and you can click on your map. According to your digital code, they will show you the resources nearby. So in this way, you
Thank
can
you so
help
much,
your
Professor
patient.
Chi.
Yeah.
Thank you so much for insightful question and answer. I think since we got the time, I would like to ask you, maybe they have one closing statement from you, what you have already suffering in the meeting today, maybe from Raf and also from Professor Chi. Maybe 1 minute, please, Prof. Raf.
Thank you very much. Well, there are so many things I understand to address, but thank you very much, Professor Shuti. It's wonderful to listen to you, and I know we completely agree on where we need to focus our efforts. And I would conclude with that look at the social gradient of health. And start with that. If you are on a governmental level, on a policymaker level, that's where you have to start, and not on the individual level. I think that's one of the most important things we can conclude. When you're in a clinical setting, in a hospital, in a general practitioner, then you can always look at who is in front of me, what is the educational level, what is the preconditions, and treat that person from where he or she stands. Those are my conclusions.
Thank you, Raf, for the nice closing statement. And the Professor Suchi, would you please, 1 minute, please?
Yes. I think it's a perfect combination for Rolf and me to do the presentations, and it's wonderful. And I thank you again, and I hope you see yourself as the change agents and as the champions and heroes in health promotion. And you can do things at different levels, and you can climb up one step after one step. But even at the clinical level, there are so many we can do. So we look at the person, and we also, as Ralph said, we also see what was the context he or she lives in, and we try to help those factors behind. So either starting from our clinical level of services or from higher level, especially from the hospital or primary care clinic level, we can also tackle social determinants for our staff, for example. There are so many things, and whatever we can do, just don't forget there is such an opportunity and power of change we can leverage. So I want to say that don't ever doubt that when a butterfly flaps its wings, it might change the world. So you are the butterflies, and I'm sure you will help your country and your community a more beautiful place. Thank you.
Thank you so much, Professor Chi and Dr. Raf, about the distinguished presentation. I think we would like to finish this meeting and session and Pleno. We would like to, from the deep of our heart and the deep of the Indonesian hospitality, for the nice presentation and also for allocation your time. Hopefully, maybe it is not the first and the second, but maybe we would like to continue to contact with you and also for sharing much better than inside in Indonesia. Hopefully, maybe not more longer. Prab, could you come Indonesia, and also Professor Chuchi too. Thank you so much for the nice presentation and also from the warm answer and question. Thank you so much for all of our participants. We hope that maybe our meeting could be getting the aims of our presentation. That hopefully the Ministry of Health of Indonesia, mostly the Director of the Health Promoting and Community Empowerment, can also continuing our relationship between HPH and PKRS in Indonesia. It is the end of the presentation and the end of the Pleno. We would like to thanks for all and thank you so much. Big applause for all of the table applause. Thank you so much. Thank you so much. Thank you so much.
Thank
Bye.
you, Suhaman.
We'll meet
Bye-bye.
again in
Bye-bye.
Indonesia soon. Thank you so much,
Bye.
Prof. Thank you so much, Mr. Harlid. Thank you so much.
Thank you, Rob.
Thank you
Bye-bye.
for the presentation. Thank you. Dikembalikan kepada panitia. Apa sudah selesai? Sebelum Ibu Dirjen nanti sampaikan.
Baik, terima kasih kepada Bapak Dr. Suherman dari IHPNet beserta Mr. Rob Harlid dan Ibu Profesor Shuchi Chiao atas waktu dan paparannya. Baik, Bapak Ibu sekalian, untuk acara selanjutnya kita kedatangan tamu di tengah-tengah Bapak Ibu sekalian. Sudah penasaran siapa yang akan datang selanjutnya? Baik, izinkan kami menyapa terlebih dahulu untuk yang terhormat Direktur Jenderal Kesehatan Primer dan Komunitas Ibu Dr. Maria Endang Sumiwi MPH. Boleh minta tepuk tangannya Bapak Ibu sekalian. Baik, untuk Ibu Dr. Maria Endang Sumiwi boleh dipersilahkan untuk naik ke atas panggung. Waktu dan tempat kami persilahkan. Baik, Bapak Ibu hadirin sekalian, sambil menunggu Ibu Dr. Maria Endang Sumiwi datang ke dalam ruangan ini, untuk mengingatkan kembali untuk Bapak Ibu bisa cek link YouTube di sesi Pleno 1 dan untuk sesi Pleno 2 juga bisa Bapak Ibu cek kembali di link YouTube sekalian. Baik, Bapak Ibu hadirin sekalian, untuk Pleno 1 tadi sudah dijelaskan oleh moderator dan narasumber. Semoga apa yang menjadi paparan dan sambutan tadi dari Bapak yang sudah memberikan sambutan itu bisa menjadi tolak ukur bagi Bapak Ibu sekalian. Dan untuk Bapak Ibu yang daring masih sehat ya. Semoga tetap fokus dalam mengikuti pertemuan jejaring promosi kesehatan rumah sakit dalam mendukung transformasi layanan primer. Baik, halo selamat siang, selamat sore Bapak Ibu yang sudah hadir di acara Pertemuan Jejaring Promosi Kesehatan Rumah Sakit dalam mendukung transformasi layanan primer yang tidak bisa hadir di Hotel Grand Safero Bogor. Ini yang online, Bapak Ibu masih dalam keadaan sehat ya? Halo Bapak Ibu. Baik, selamat datang. Boleh kita minta tepuk tangannya sebentar sekali lagi? Selamat datang untuk Direktur Jenderal Kesehatan, Primer dan Komunitas, Ibu Dr. Maria Endang Sumiwi, MPH. Baik, untuk Ibu Dr. Maria, izin Bu, boleh datang dan naik ke atas panggung untuk memberikan sambutan serta laporannya. Untuk waktu dan tempat, dipersilahkan.
Terima kasih. Assalamualaikum warahmatullahi wabarakatuh. Selamat sore, salam sejahtera untuk kita semua. Om Swastiastu, Namo Buddhaya, salam kebajikan, rahayu, salam sehat. Yang saya hormati para direktur rumah sakit vertikal atau utusan, rumah sakit umum daerah, rumah sakit swasta di seluruh Indonesia, ada yang mengikuti melalui daring ya, atau yang mewakili, para kepala dinas kesehatan provinsi, kabupaten, kota di seluruh Indonesia atau yang mewakili para narasumber dan para peserta yang berbahagia. Kita bersyukur pada Tuhan hari ini kita berkumpul dalam keadaan sehat mengikuti acara pertemuan penguatan jejaring layanan kesehatan rumah sakit dalam rangka transformasi layanan primer. Jadi Bapak Ibu, ini saya rasa pertemuan pertama atau bukan? PKRS. Terakhir 2022. Jadi selamat berjumpa kembali dengan topik PKRS di 2024, itu pun akhir tahun ya. Karena agak terlupakan. Artinya kalau 2 tahun nggak ketemu. Tetapi saya ingin menyampaikan beberapa hal ya. Meskipun judulnya transformasi layanan primer, sebetulnya ini bukan hanya tentang transformasi layanan primer ya. Jadi ini karena kebetulan nama budgetnya itu transformasi layanan primer. Tetapi pasti nanti ada kaitan dengan transformasi layanan rujukan. Jadi Bapak Ibu, ini masuk dalam agenda kerja-kerja kita transformasi kesehatan. Transformasi kesehatan, utamanya kita ingin masyarakat kita sehat. Yang mau sakit tidak jadi sakit, yang sudah sakit tetap produktif. Sehingga tidak menjadi penyakit yang membuat tidak bisa bekerja. Gitu. Nah, karena itu health promotion menjadi sangat penting. Nah, health promotion ini gimana kita menerjemahkan health promotion ya, gitu. Untungnya kita ini penerus, gitu. Sehingga sebelumnya sudah ada yang merumuskan. Nah, rumusan pertama itu yang menjadi babonnya promosi kesehatan, yang kita sebut Ottawa Charter. Nah, Ottawa Charter ini boleh ditampilkan nggak? Ini sambutan tapi sekaligus diskusi ya. Ini untungnya kita sedang menulis RPMK. Nah itu oknum ada di belakang namanya Pak Sakri. Ini beliau yang menjadi focal point untuk nulis rancangan Permenkes promosi kesehatan. Nah ini kita pakai yang acuan semua orang nih Ottawa Charter untuk scope of work-nya health promotion. Nah, ada yang untuk individu, keterampilan individu. Oh, setiap orang harus tahu cara cuci tangan pakai sabun, hidup bersih dan sehat, gizi yang baik, dan seterusnya. Jadi yang ini ya, ini yang keterampilan individu. Lalu gerakan masyarakat, oh ini masyarakat harus berpartisipasi untuk hidup sehat. Karena butuh lingkungan yang sehat, determinan kesehatannya itu banyak ya, termasuk yang determinan ekonomi ini sekarang sedang, determinan komersial ini sekarang sedang gencar-gencarnya. Kita digempur oleh iklan-iklan makanan, minuman kemasan. Nah itu masuknya di sini harusnya nanti, termasuk di sini kebijakan berwawasan sehat. Tapi kita untuk hidup sehat ternyata mengadopsi perilaku hidup sehat itu ternyata lawannya banyak. Karena ada banyak pesan-pesan yang berlawanan dan itu lebih gencar daripada kita. Jadi ini gerakan masyarakat penting, lingkungan yang mendukung itu adalah gimana sih supaya orang-orang mudah hidup sehat gitu. Lingkungannya harusnya membuat orang itu gampang mengadopsi hidup sehat. Dan kebijakan berwawasan kesehatan, tetapi yang berkaitan dan menurut saya paling penting untuk saat ini, reorientasi pelayanan kesehatan. Jadi promosi kesehatan juga harus menjadi nyawanya pelayanan kesehatan. Nggak hanya di layanan primer, tapi juga di layanan rumah sakit. Nah ini evidence cukup banyak ya Bapak Ibu, sudah banyak cukup bukti ilmiah. Kenapa? Karena ini sekarang kita temanya rumah sakit. Kenapa rumah sakit itu WHO menganjurkan supaya menjadi health promoting hospital, yaitu rumah sakit yang mempromosikan kesehatan. Kenapa? Karena kalau tidak begitu, economic cost-nya tinggi. Dan ini sudah diteliti ya, coba dilihat yang baru saja keluar nih, sebulan yang lalu kalau nggak salah, di The Economist. The Economist itu yang ini majalah ekonomi ya, tetapi membahas kerugian kesehatan karena rendahnya literasi. Dia membahasnya untuk di Eropa dan di Cina. Ternyata di sana nggak bagus-bagus amat juga literasi kesehatannya. Nah, di sini mana ya? Nih hasilnya, kalau literasinya jelek, itu hospital readmission. Orangnya udah pulang, harus kembali lagi karena nggak bisa jaga ketika pulang. Jadi nomor satu, biaya yang sebesar ini ya, kerugiannya ini kalau dirupiahkan nggak tahu udah triliunan ya, 2 sampai 4 miliar euro. Itu kalau 4 miliar dolar aja tuh 60 triliun ya. Ini kalau di UK. UK itu mengalami kerugian segini karena literasi kesehatannya jelek. Literasi kesehatan yang jelek menyebabkan apa? Hospital readmission atau rehospitalisasi. Kemudian ini yang terutama ini. Lalu pasien struggle to self-manage their condition. Jadi nggak bisa memanage kondisinya. Ya, kemudian increase incidence of preventable health issues yang bisa dicegah, tapi juga dries up reliance on emergency service. Sehingga datang kalau udah gawat dan itu jadi mahal. Nah ini apa yang terjadi untuk konteks rumah sakit. Jadi kalau kita nggak mulai health promoting hospital, maka cost itu terhadap kesehatan akan tinggi karena hal-hal ini ya. Hal-hal, oh nanti dia terpaksa harus rawat inap ulang karena nggak bisa menjaga. Kemudian atau dia nanti datang kalau udah gawat sehingga lebih mahal, butuh perawatan lebih intensif gitu ya. Nah ini kerugian yang ada kalau kita tidak menuju peningkatan health literacy. Nah sekarang kita melaksanakannya gimana? Pertanyaannya kan begitu. Nah ternyata ini kalau saya mendengar-dengar ya, situasinya gimana health promotion di rumah sakit. Pak Menkes selalu menyampaikan, ada beberapa hal yang beliau sampaikan ya. Health promotion harus jelas targetnya siapa. Nah ternyata saat ini masih ada percampuran antara health PR, ya kan? PR rumah sakit, marketing rumah sakit dengan health promotion. Health promotionnya tuh jadi masuk ke situ ya sebagai satu kegiatan. Padahal kalau pakai ilmunya Pak Menkes, target sasaran harus jelas, itu sasarannya sangat berbeda. Kalau marketing sasarannya keluar supaya menggunakan layanan kita. Kalau health promotion sasarannya ke dalam, yaitu masyarakat yang sudah ada di dalam rumah sakit kita, ya kan? Yaitu pasiennya, kemudian keluarga pasiennya, kemudian tenaga kesehatan di rumah sakit. Contoh yang nyata apa Bapak Ibu? Sebetulnya kedua hal ini akan berhubungan ya. Contoh yang nyata ini saya punya teman, dia lututnya sakit. Sudah ke dokter paling jago ya, dokter Niko. Untuk mau rencana lututnya mau diapain. Tapi nggak puas juga. Jadi dia ke Singapura. Jadi saya tanya, kok nggak ke dokter Niko aja? Oh kalau sama dokter Niko penjelasannya 5 menit doang. Kalau di Singapura dijelasinnya 1 jam. Nah itu Bapak Ibu kalau tanya-tanya ya, tanya-tanya ke semua orang yang pergi ke luar negeri, mereka tahu kemampuan rumah sakit kita udah bagus, tapi mereka nggak dapat penjelasan. Jadi sebetulnya ke Malaysia cuma pengen denger penjelasannya, saya tuh sakitnya apa, saya tuh harus gimana, supaya nggak usah rawat lagi harus gimana. Nah itu rupanya itu nggak terjadi di rumah sakit Indonesia. Jadi Bapak Ibu itu bagian dari health promotion. Aku boleh minta tolong satu slide Mas Dito, mana ya? Slide-nya Mbak Sari yang dari Singapura yang tadi pagi dipresentasikan, yang alur pasien ya di poliklinik yang di bawahnya Singapore General Hospital. Nah nanti saya sampaikan. Jadi Bapak Ibu tadi udah mendengarkan narasumber luar negeri ya. Jadi kalau untuk pasiennya health promoting itu harus gimana? Ini kan pasien-pasien udah terlanjur sakit, ya kan? Health promotingnya kita pengennya dia tetap sakit tapi bisa di-manage, bisa hidup produktif. Lalu kalau untuk keluarganya bisa care, untuk care-nya gimana gitu kan. Lalu juga untuk tenaga kesehatan sebagai komunitas rumah sakit. Gimana cara berkomunikasinya dan seterusnya. Nah, health promotion yang bagus, health promoting hospital yang bagus akan membantu marketing Bapak Ibu. Saya rasa nanti yang diminta Pak Menkes kan semua rumah sakit vertikal, tentu saja tidak hanya vertikal ya, itu harus layanannya unggul. Dan yang layanan unggul itu diterjemahkan melalui apa? Patient experience. Jadi Pak Menkes kan mintanya kita paling bagus se-Asia kan? Asia atau Asia Tenggara? Kan 3 ya, layanan unggul, kemudian pengampuan sama penelitian kan kalau rumah sakit vertikal. Layanan unggulnya disuruh mulainya dari mana? Dari patient experience. Makanya kemarin parkirannya dibenerin, antriannya dibenerin. Jangan lupa patient experience yang dicari. Kenapa orang ke luar negeri? Itu adalah health promotionnya. Karena kita nggak ada komponen itu. Jadi ini yang kita, yang alur Mas. Terus, bukan. Alur yang ada education yang terakhir, bukan ke depan lagi, dari depan aja deh kita cari, bukan ke depan yang poliklinik. Contoh polikliniknya di mana tuh? Depan atau belakang? Coba, nggak ada ya? Yang ada alurnya gini, ada garis-garis, gambar garis-garisnya. Ada alur, oh pasien itu ditangani siapa. Coba ke bawah lagi Mas. Ke bawah lagi. Terus. Nah itu, 25, slide 25. di slideshow ya. Nah, ini contohnya ya. Ini contoh, ini teman-teman kita kirim untuk lihat layanan primer sebetulnya di Singapura tuh gimana. Nah, ternyata mereka bagusnya itu ada case manager, lalu terakhir ada health plan ya. Ini apa? Tulisannya nggak kelihatan. Hah? Health plan kan ini ya, health plan atau health goals. Itu terakhirnya, ya kan? Jadi setelah ketemu ini, nah ini ada case manager, lalu ada health plan. Jadi sesudah selesai dia harus dibantu supaya punya rencana untuk mempertahankan kesehatannya. Jadi semua ini kalau di Singapura setidaknya di poliklinik yang dijalankan untuk masyarakat ya, itu masuk tuh. Health promotingnya masuk di dalam alur layanan. Nah, saya juga tanya, kok bisa 1 jam ya jelasin gitu. Rupanya memang nggak harus DPJP-nya yang jelasin. Bisa case manager yang diassign khusus untuk menyimpulkan ininya dan menjelaskan. Nah, ini bisa menjadi salah satu pilihan-pilihan ya Bapak Ibu. Nah, ini contoh-contoh gimana kita bisa mengembangkan health promoting hospital. Tetapi tujuan kita satu, ini yang ke rumah sakit yang sudah terlanjur sakit. Nah, karena terlanjur sakit maka tugasnya health promotingnya terutama gimana supaya bisa hidup tetap produktif meskipun dalam keadaan sakit. Nanti ada compliance, ada segala macam. Nah, itu yang bisa diterjemahkan di dalam health promoting hospital. Nah, ini seakan-akan kontradiksi ya. Kan kita harus bornya tinggi. Kita harus bornya tinggi tapi kita harus menjaga jangan balik lagi. Nah, saya rasa bor tinggi tidak harus dari masyarakat yang status kesehatannya jelek kan. Tapi bisa jadi kalau kita health promotingnya bagus, justru seperti orang-orang yang pergi ke Malaysia hanya untuk mendengar saya ini kondisinya gimana, obatnya apa, supaya nggak itu gimana, itu nanti bisa ditangkap oleh teman-teman di rumah sakit. Supaya terjadi yang disebut tadi patient experience yang bagus. Kalau Bapak Ibu nanti bisa menjalankan health promoting hospital yang bagus, saya rasa patient experience di rumah sakit itu akan lebih baik. Sehingga nanti mereka senang ya dengan pelayanan rumah sakit. Nah, beberapa kali kebetulan saya Dewas di Cipto ya. Beberapa kali saya lihat dalam pelayanan-pelayanan yang teknologi tinggi ya, seperti transplantasi hati, itu keluarga dan anak-anaknya sangat memberikan respon yang sangat baik sekali, karena mendapatkan penjelasan yang cukup lengkap ya, dan diperlakukan seperti apa. Nah, itu moga-moga bisa menjadi kebijakan pelayanan secara keseluruhan di rumah sakit. Nah, ini Bapak Ibu kita membangun kembali setelah 2 tahun belum ketemu lagi untuk evaluasi dan juga mendapatkan masukan. Saya rasa nanti kita juga akan merevisi kalau diperlukan Permenkes standar kita, karena sudah ada Permenkes ya untuk pelayanan untuk promosi kesehatan di rumah sakit atau PKRS. Sehingga nanti Bapak Ibu saya lihat di jadwalnya di sesi terakhir itu ada PKRS. Nah, meskipun tadi ya judulnya layanan primer, karena budgetnya layanan primer, sebetulnya ini juga mestinya masuk di dalam transformasi layanan rujukan, terutama pada bagian mewujudkan layanan yang unggul agar pasien experience itu membaik. Saya rasa health promoting hospital menjadi salah satu upaya yang sangat strategis untuk memberikan patient experience yang baik. Tentu saja tujuan utamanya adalah menjaga masyarakat tetap sehat, karena kita mau mewujudkan Indonesia maju. Kalau bisa yang sudah sampai di rumah sakit dikembalikan sehat, atau dikembalikan meskipun sakit termanage dengan baik, nggak hanya oleh klinisi tapi juga oleh pasiennya sendiri, supaya nanti bisa hidup produktif. Karena menurut Pak Presiden kita pengen 8% pertumbuhannya. Kalau masyarakatnya sakit nggak bisa mencapai, supaya bisa menjadi negara maju. Mungkin itu yang bisa saya sampaikan Bapak Ibu. Terima kasih atas kehadirannya. Mohon kontribusinya nanti di dalam diskusi-diskusi supaya bisa kita terjemahkan dalam kebijakan maupun dalam standar. Nanti masuk di dalam kebijakan rumah sakit kita. Nanti saya minta Bu Elvi supaya kalau ada champion yang ingin mencalonkan diri, kami bisa jadi contoh nih. Health Promoting Hospital mungkin di salah satu rumah sakit vertikal ya. Nanti diskusi sama Bu Sari atau Pak Narto supaya bisa ada salah satu contoh Health Promoting Hospital di tempat kita yang terbaik seperti apa. Mungkin itu Bapak Ibu, selamat mengikuti pertemuan ini. Semoga pertemuan ini berjalan dengan lancar dan semoga juga menyenangkan dan membangkitkan semangat, karena saya rasa ini wilayah yang masih banyak perlu kita garap bersama, karena saya rasa gapnya cukup besar ya. Semoga kita bisa mengubah wajah rumah sakit kita sehingga menghasilkan patient experience yang baik. Terima kasih. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam. Ibu dokter, mohon maaf izin sebentar. Kita akan melanjutkan untuk sesi foto. Jadi Ibu boleh izin kita tetap standby di atas panggung. Dan untuk Bapak Ibu sekalian bisa izin untuk maju ke depan. Kita akan ada sesi foto bersama di atas panggung. Boleh Bapak Ibu silakan maju ke atas panggung. Sebelumnya Ibu Dokter Maria, terima kasih untuk sambutannya. Silakan Bapak Ibu, boleh naik ke atas panggung, kita semuanya berfoto di atas panggung. Mungkin bisa dibagi dua ya. Izin Bu, badannya agak serong. Badannya agak serong. Bapak-bapak, boleh? Boleh silakan. Boleh satu baris Pak, takutnya di belakang nanti tidak terlihat di kamera. Di samping Bapak, di tengah, ya boleh. Badannya serong, izin Bapak Ibu. Ibu dibagi dua, di sebelah, ya. Boleh satu lagi di sebelah situ Ibu, izin. Baik, boleh agak rapat, izin Bu. Baik, sudah siap Bapak Ibu? Boleh berikan senyum yang paling manis ke kamera. 1, 2, 3. Boleh paling manis senyumnya. 1, 2, 3. Oh baik, ada gaya lain ya. Sudah siap semuanya? Tangannya tetap di dada semuanya. Ada gaya lain? Bapak Ibu ada gaya lain? Oke, selanjutnya kita akan take video ya. Sudah siap semuanya? Aba-abanya sudah ada? Oh baik. Boleh pakai suara mungkin ya, biar lebih ramai ya. Izin ya Bapak Ibu ya, ada suaranya boleh ya, dada-dadanya ya. Oke, mulai. 1, 2, 3. Baik, terima kasih Bapak Ibu sekalian. Baik. Setelah ini kita akan ada coffee break Bapak Ibu sekalian. Kita sudah sediakan di luar area ballroom dan kami akan memberikan waktu kurang lebih 15 sampai 20 menit untuk coffee break. Setelah itu kita akan melanjutkan untuk sesi pleno yang kedua. Dan untuk membuka link YouTube, Bapak Ibu nanti bisa cek di link YouTube-nya untuk sesi pleno 1 dan untuk sesi pleno 2-nya juga tersedia di link YouTube masing-masing. Terima kasih.